far we get. Okay, so this is a real case. This was a 38-year-old lady who was brought to the emergency department in our hospital. Sorry. Oh, no, it's the wrong patient. 1 second. We wanted to start with a different patient, actually. I apologize. I just need to get the other patient. This is the one we wanted to start with. Four, yeah. Sorry about that. That's my fault. There we go. Yeah, I've got it. Yeah. Oh. Okay. So this was a real scenario, and I was involved at the time. So a 71-year-old lady presented to the local hospital. And this is her background. As you can see, she suffered from diabetes. She had some liver problems. She was known to have impaired cardiac function. And she had chronic kidney disease with an estimated GFR normally at around 35 mils. And she also had, in the past, had cardiac surgery and had an aortic valve replaced. And she presented to the local hospital complaining of feeling unwell, lethargic, and had noticed she had a fever. And the medical team in the emergency department noted that she had a murmur. She was indeed febrile, and clearly they thought of endocarditis, given that she had a prosthetic valve. And in this hospital, it was protocol to treat suspected endocarditis with gentamicin and benzopenicillin. Her blood culture remained negative, but they had been taken after the antibiotics had been started. So, but she got treated for possible endocarditis, was awaiting a TOE, but unfortunately developed progressive kidney injury on the background of advanced chronic kidney disease. And this was precipitated by her illness, but also some aggressive fluid resuscitation. And a couple of days later, the team contacted our hospital, mainly because the cardiac surgeons are based in our hospital, and asked whether she could be transferred to us. And we just need to get the screens back. Perfect. They wanted some cardiology and cardiothoracic input, given the possibility of endocarditis. She arrived in the cardiac high dependency unit, but was very breathless, and on review was in clear pulmonary edema. So she got transferred to the critical care unit, and the team, she was close to being intubated, and the team decided that renal replacement therapy was indicated to remove fluid, to treat a pulmonary edema, and hopefully to avoid an intubation. And as you can see, a line was inserted. And then she had CRRT. And the first filter lasted for 28 hours. Fluid was removed. The next filter only lasted for 21 hours. She had treatment according to our usual protocol, which has citrate as the first-line anticoagulant. Fluid was removed, and for some reason, both first filters didn't last as long as we had expected. And then another filter got started, and it only lasted for 11 hours. And so this is when somebody asked me and said, what should we do? And these were the options. Maybe citrate just wasn't good for her, maybe it wasn't working, maybe there was something else, but the question is, what would you do? Sorry? Yeah, I agree. I think that's what I said. I said, oh, it's obvious. She has a groin line. It's only 15 centimeters. That's the problem. Now, obviously, it was inserted at the time, and she was very breathless, and she couldn't lie flat, and that was the best they could do at the time. And in the midst of this emergency, they forgot to choose the right, or didn't look at the right length. But anyway, that's what happened, a 15-centimeter line, and I thought this would then all be solved. And just as a reminder, these are the tables which you also saw earlier, that we need for the circuit to remain patent and for CRRT to work, you need an appropriate catheter of appropriate length in the right vessel. Now, that got inserted, and it still didn't really work properly. Now, was there anybody in the room who thought we should reduce, who didn't like the ionized calcium concentration? Is there anybody concerned about the ionized calcium? If not, we put this up because we discussed it. And we discussed it because certainly in the UK, we use blood gas machines to measure ionized calcium and to measure the post-filter ionized calcium concentration. And as I said, we aim for a calcium concentration around 0.3. But we have to say that the blood gas machines were never made for this purpose, and in fact they're not validated to measure calcium in this range. And when you really put this to a test, as was done by some people, by colleagues, then the same sample containing a particular ionized calcium concentration of around 0.3 had different values when 6 different blood gas syringe machines were used. And it's not a problem with the machines. The machines were never made to, and they're not licensed to measure ionized calcium concentrations. We use them to guide our therapy. But it is possible, for those clinicians who may switch the measurements and use different blood gas machines from different companies, you need to be aware that you may get different results. And if you notice that your citrate protocol suddenly doesn't work anymore after you've changed the blood gas machine company, then it could all be related to the fact that you just have ionized calcium measurements in a different range. And it shouldn't be a problem if you use the same machine all the time. But it is a problem if people switch between different machines. And I just want to bring this in here as a word of caution, and also to say that the machines, what we do to allow us to deliver citrate-based anticoagulation is we use a machine which wasn't meant and isn't licensed for this. But in any case, the issue here, I thought, was the problem that the vascath was too short. It was 15 centimeters, and so it got replaced, and the next filter lasted 8 hours. So the next question then was, why was there anything else wrong? We looked at the bloods again. Here they are. And the question again, or maybe a little bit, what would you do at this moment in time? So the citrate protocol was followed. The people who were delivering CRRT were fully compliant with our protocol, which worked well normally. We were using the same blood gas machine as always. The catheter was now changed to an appropriately sized catheter of the right length, and still it lasted for 8 hours. Say it again. DIC?
The mics are there in the center of the room, so anyone wants to talk, you can use them.
DIC based on the INR?
The fibrinogen is low, and the platelets are dropping. Consumptive coagulopathy is there. So maybe there is a severe adsorption is happening. So that I would like to increase the pre-filter replacement fluid.
Okay, so what I didn't put up is she was actually in CVVHD mode.
Oh, okay.
I should have said that. So she, the protocol, our standard protocol in the unit where I work is CVVHD as the first line modality with citrate. So she received CVVHD.
Yeah.
But still, anyway, you think it,
Yeah, I
you're
was thinking
concerned
that
it
is
could be
fine.
DIC?
Yeah.
Okay, what would you do then, if that's what it is? What would you do? She needs renal replacement therapy. How would you deal with this?
Maybe what I will change to CVHDF mode or simple CVHF mode.
Okay,
And I'll go with the replacement fluid with increasing the pre-filter.
okay.
Yeah.
And what would anticoagulation would you give?
I would like to continue the same
citrate.
citrate, yeah.
Okay, so you change the modality and the flows in the
Yes.
filter. Okay,
Thank you.
good idea. We didn't do that, but yeah. Anybody else? She needs CRRT. She's still in pulmonary edema. You have to do something. We could stop, but then she will stay in pulmonary edema. What would you do? It was a real patient in front of us. Anything else you're concerned about? Sorry? Let me give you a clue. Let me give you a hint. So, the patient needed CRRT because fluid had to be removed and she was no longer passing any urine and she was in pulmonary edema. Whatever we were doing wasn't working. It was the filter was clotting. The question was whether for some reason citrate wasn't working, for whatever reason, and maybe we needed a different anticoagulant, or we just had to admit defeat and give her high-dose diuretics, hoping that she would suddenly start passing urine, or do something else. Prostacyclin? Yeah. So we could do that. If we really thought that the citrate wasn't working, we could change to a different anticoagulant. I was unable to figure out why the citrate, which was given and administered at as usual according to a protocol and where all the various parameters were in target, shouldn't be working. It should have worked. But that would be an option, that you say, well, just use something else than prostacyclin. It's a weaker anticoagulant, much weaker than citrate. And you could try that out. So I don't want to drag this on, but essentially what happened was that she had hit. And when you go back, you will see that she had this continuous fall in platelet count. So she was also receiving heparin for DVT prophylaxis and had developed HIT. So she had developed antibodies against the platelet factor 4 complex, and they were in the context of her receiving regular heparin as a DVT prophylaxis. She had ongoing progressive HIT, and this was essentially stopping the citrate from working. And that's the point. If citrate is clearly a very, very, very effective anticoagulant, but if patients still have premature clotting and they are receiving heparin, then you have to make sure that you've excluded HIT, especially if there's this fall in platelets. And it doesn't happen very often, but when it happens, then the only solution is obviously to stop the heparin. And then the citrate works again. But there are various case reports in the literature just alerting clinicians to this possibility. So as soon as we stopped the heparin, the DVT prophylaxis, the citrate started working again effectively, and the filters lasted for more than 72 hours. But citrate is a therapy if you've got HIT and you need an anticoagulant, but it does not protect against HIT if patients also need heparin. And that's really the message of the case. Any questions? If you go to the literature, there will be some case reports and also citrate review articles mention this possibility. And it's not very often, but it does happen. Yes? We can. If there are no questions, then we can do another case? Yes, okay. But shall I do one more, then you do yours? Yeah, okay. Okay, so we now have a case for which there is no right or wrong answer. Okay, this was a 38-year-old lady who presented to our emergency department with confusion. And as you can see here, she had a significant past medical history, which of note included liver disease, and she was active on the liver transplant waiting list. Her usual medication consisted of diuretics, including spironolactone and metformin. She came to the emergency department with a temperature. Blood pressure was lower than normal, and initially her oxygen saturations were okay at 98% on room air. She was jaundiced. She said her abdomen was more distended than normal, and she had obvious bulging flanks, and she was edematous. And here we have her blood results on admission in the emergency department. Now, obviously, the striking features are that her sodium is a bit lower than normal. Her creatinine was above her baseline. Her baseline was normally 80, so 1 milligram per deciliter. Her albumin was low, and her INR was deranged. It was 3.1, as you can see. And she was a bit acidotic with a bicarb of 16. The full blood count is here. She was anemic, and her white cell count was up. A urine dipstick was done routinely in the emergency department, showed a bit of protein and a bit of blood, and she had some bacteria on urine microscopy. She deteriorated quite rapidly in the emergency department, in particular became very obtunded, and then was intubated in the emergency department because she was encephalopathic and progressively obtunded. In the intensive care unit, she was started on broad-spectrum antibiotics for presumed sepsis, septic shock, and she, following intubation, rapidly needed vasopressor support. There was concern about her abdomen and ascites and possible spontaneous bacterial peritonitis, but the paracentesis, the acidic tap, was unremarkable. And really, as soon as from the minute she arrived in the intensive care unit, she produced very little urine, 20-25 mL per hour. Because she'd been so confused and obtunded, she had a CT scan of her head. It showed no cerebral edema. And then the nephrology colleagues were consulted because a repeat blood sample 6 hours after admission showed worsening of her creatinine. Creatinine had risen from 165, baseline being 80, to 185. And here we have the rest of her blood results 6 hours later. And I want you to imagine you're the nephrology colleague who gives the consult. So at this moment in time, would you start renal replacement therapy? Do you think she would benefit from renal replacement therapy? Do you think there are some other things you could do and renal replacement therapy would have more complications than potential benefits? Or do you need any other information before you proceed and give an opinion? So is there a role for renal replacement therapy at this moment in time? Who says yes? Okay. Why would you give it? Why would you start and put this lady with an INR of 3 on renal replacement therapy?
So there's worsening acidosis. There is probably evidence of sepsis. These would be my, I mean, I would also go for a blood culture and probably start antibiotics as well.
She was started on antibiotics, yeah. She was on antibiotics. So the indication for you would be to do what? To clear cytokines and to correct the acidosis. Okay?
The ammonia is going up, and ammonia coincides well with raised intracranial tension. So that would be an additional reason to start renal replacement therapy. And also this lady is on a liver transplant waiting list. So she needs to be optimized so that if she does get a liver, she's in a position to receive it.
Okay, I hear you. But she's just had a CT scan and showed no cerebral edema. And she has an INR of 3.1. And she may be bleeding. But your indication would be, or your reasoning is the ammonia.
Yeah,
Okay.
hi ma'am.
So anybody who wouldn't start at this
So
moment?
no, I will start the therapy for sure. My
Okay.
reason would be because patient is apparently anuric. She's got a high NCAF metabolic acidosis with lactate predominance. She's in hepatic NCAF. Rather, it's not mentioned there is any evidence of bleed. But if there is INR of 3.1 but the patient is not bleeding, I'm not worried about that point.
Okay.
But if I'll do the therapy in a appropriate time, I might be in that window to save the patient and bring that parameters down, along with leading her to be in the fluid overload in next hours because she's getting albumin also and she's anuric. So preferably, yes, I will prefer to do a renal replacement therapy.
Okay, so you think the benefits of CRRT outweigh any potential complications and risks? Okay. Is there anybody in the room who wouldn't start? Okay. Why would you? As I said, there is truly no right or wrong answer here.
I would consider CRRT, but before that, I would see what is the blood pressure, how many vasopressors, and whether there's a decreasing trend of vasopressors or an increasing trend. And I would consider a furosemide stress test.
Okay.
And see if there is any chance of, the kidneys restarting. So if the furosemide stress test is negative, I would go ahead with the CRRT.
Okay. So the person who came to see this patient said exactly the same. The person said, I don't think there's an absolute indication here. You can still give some furosemide, and the creatinine is only up a little bit, and there was no edema on the CT. We can wait. And that's what was done. So the next day, we have these blood results here. This is without CRRT. And imagine you're the nephrology colleague again who's come back for the consult.
So I can see the renal function worsening. I can see the hepatic encephalopathy, high INR, low sodium. So I guess the MELD sodium score must be more than 25. So what the patient needs is something more than CRRT. So I need to take out the protein-bound toxins also. So possibly there should be a parallel CRRT plus MARS or CRRT plus PLAD or something like that. Because there is no cerebral edema, there is no structural damage. So there must be uremic toxins plus the protein monohepatic toxins. So that I think should be tried.
Okay, so CRRT plus liver support.
Yes, yes.
Okay, and the CRRT is for, why are we giving CRRT?
For two reasons. For hepatic dysfunction, no other renal replacement therapy is better than CRRT. That is first. And second thing, there is a progressive worsening of the parameters.
The creatinine is coming down.
It could be the dilutional because she's gaining some fluid also. So the hypocreatinemia may be dilutional. So I won't buy that creatinine. But
okay, so you think it's just diluted?
Yeah.
Okay. Okay.
Because the pH is steadily coming down. If we could see the 7.2 now.
Yeah, that's correct. So one option would be CRRT and MAR and liver support. Any other solutions? Does anybody want to hold off?
Ma'am, I think sepsis is worsening. The TLC count is going up from 18,000, now it is 24,000. Suppose if it was dilution, so it has to be come down now. So I think there is something else. Right now, one thing is that the bicarbonate is coming down from 16, it has come down to 12. And sodium is holding up, creatinine is coming.
One thing I just need to ask, is there any evidence for pyelonephritis? Because there were some pus cells in the urine.
Yeah, there is, and that's here. So it's actually more than pyelonephritis, bacteremia. So the blood cultures grew Klebsiella from blood and urine, and the antibiotics then were changed
and
to...
hope the metformin has been withheld.
So, when you'll be, as the nephrology colleague, giving a consult, this is also what the team tells you. So we have a clear bacteremia, we have urosepsis, urine output was poor, and we had these results which I just showed you. So we have one suggestion to give CRRT and liver support, and I think you were just going to do CRT, is that right? I think we just had CRRT in isolation. In defense, I'm just making, the creatinine is falling, she's not massively overloaded. Is there anybody who would want to wait? What would the people do who haven't spoken yet? John, what would you do? You haven't spoken.
Okay, what would I do? I think that the treatment of this patient with CRRT needs to be seen in the context of the whole patient and what the clinical goals are. So if this patient we think has got sepsis and septic AKI, well, that is potentially reversible. And obviously their performance status was not bad beforehand, so they were listed for liver transplantation, although they are not going to be transplanted in the UK as a chronic liver disease patient from the setting of ICU. They would have to be well discharged from hospital back home again. So if this was a fulminant hepatic failure, but acute hepatic failure patient, they would already be on CRRT, I think, and on other forms of multi-organ support. So I think really the main abnormality there is the acidosis. I don't know how bad the CO2 is or what the ventilatory support is at the moment, but that's probably not going to be sustainable, particularly on the high-dose vasopressors. So the question is whether you want to give some sodium bicarbonate, or whether or whether one wanted to give CRRT in order to address the fluid balance issues that are probably going to arise. As you say, there's some I think one of the downsides of CRRT is the thrombocytopenia, and that could be worse with the extracorporeal circuit. So that can obviously be replenished. Again, if it was a fulminant hepatic failure, you'd be more worried by the ammonia. Probably the chronic patients I wouldn't be so worried about. So I think you've kind of probably got to have a little bit of a case conference about which direction this patient is heading in. Are they in a sort of fulminant downhill course where they're going to die and we possibly should avoid over-medicalising an unsalvageable situation, or are we going for it, in which case probably a combination of acidosis and fluid balance will drive you towards a trial of CRT. The creatinine is almost meaningless in this situation. I'm trying to say your units have gone something completely wrong, but even in micromoles per litre, that creatinine it could be any GFR really. It's between 0 and 20 or something like that in a patient with this severity of illness and liver failure in addition. Urea a bit more influential. Is that supposed to be in millimoles per litre? Yeah. Well, that's actually quite a high level of urea. And again, there will probably be some evidence to suggest that that was probably maybe more of a contributor. So if the hepatologists think that the patient is worth a go, then I would probably give a period of CRRT, but with the knowledge that when people develop sort of 4 or 5 organ failure from the context of chronic liver disease in the ICU, the survival is very, very low.
Sure, but at the moment we were geared up to, we wanted to do everything possible to get
So long answer, I think probably I would crack and give CRT now.
Okay. And Ravi, yes, Ravi.
I think this is a really fascinating case for many different aspects. And I think as John has pointed out to you, you have choices. And there are 3 choices that were being made. The first choice was when, and that when was already delayed, in my mind, to 24 hours. So that was the first question. The second is what, and as John pointed out, you could have started off with correcting the acidosis with bicarbonate. And then the third choice is essentially with what modality would you do? And I think in all of these, when you put this in context of the patient, you start seeing if this is a patient who's going to get a liver transplant, the MELD score is already high up there. But the point which is going to dictate when she gets a liver transplant is availability of a liver. And in most instances, at least in our setting, if the patient is on a vasopressor and has gone on to vasopressin, most of the liver transplant surgeons will not touch the patient till they're off that vasopressor, because they really are concerned about the liver being able to survive that. The second is if there's an episode of sepsis here, that sepsis is going to take time to resolve, whatever the source, and she's got Klebsiella, she's got all that. So in this case, I don't think that there is anything but that you would start. I would probably have started at the point where it was 6 hours out into it, because what you're anticipating is the course. And that's the most fundamental aspect when you see these patients, is not so much avoiding the therapy, but accepting the fact that the therapy is going to support other organ function. And here, you're not dealing with the kidney. You're using the CRRT and replacement therapy as organ support therapy, just like as you would use a ventilator. So it doesn't have to wait till you failed, till you start, but that's an approach which starts asking you to think about a conceptual framework which is different than we normally are used to, looking at conceptual frameworks of dialysis being applied only when the kidney has failed. So for all those reasons, if she had started on CRRT, say, at 6 hours, or at the time point that she was being first considered, chances are you would have a better optimized state and not wait till this point now to recover lost ground, which you will now take a lot longer to do so.
Thank you, yeah. So at this, after 24 hours, CRRT was started. It was acknowledged that the creatinine and urea were probably completely misleading, and in the context of liver disease and sepsis were not reflective of kidney function. And this slight drop in creatinine did not mean improvement of kidney function. And the concern by the team was that we had positive blood cultures. It would take even in the best scenario, it would take her a couple of days to recover from that. So the kidneys would take longer to recover, even in the best scenario. And the ammonia was of concern, and I should add, in the liver unit close to our hospital, they often use ammonia as an indicator to, or as one of the triggers to decide when not to start or when to withhold. It's just because ammonia is obviously also cleared by the kidneys. So after 24 hours, the therapy was started. But it led to a lot of discussion amongst different people, and it was, there were also colleagues who at the time felt that we didn't have an absolute indication. So there is no right or wrong answer. The good news was she was started on CRRT, she took a couple of days, and I think within a week she was off Pressers and also of our CRRT.
I have a comment here. So somebody suggested that, for the acidosis, we should end up giving the patient some bicarbonate. And we have a lot of eminent nephrologists here, and I just want to ask, how good is giving bicarbonate in an iron gap acidosis? Because, I mean, what really happens to the intracellular pH? And does it really help the patient at all? And, I mean, obviously the main culprit is the unmeasured acid which is there in the blood, and we have to end up removing it. So, I mean, can we delay CRRT, by justifying it by, replacing bicarbonate?
John is actually an expert in bicarbonate. Do you want to answer this?
All I would say is that unfortunately a CRRT machine is a bicarbonate infusion with volume control and sodium control. So as I've said, we're not going to be removing very significant amounts of lactate. If the acidosis is a renal acidosis, then admittedly there may be some sulfates and things like that, but there will be predominantly a hyperchloremic acidosis, and so that, well, at least we can correct. We don't have the full acid-based picture here. But I think that, and then in terms of the intracellular acidosis, really that's a phenomenon of giving very large volumes of bicarb during apnea in a cardiac arrest kind of situation. So we've taken bicarb off the cardiac arrest protocol, but bicarb being given as a slow infusion, you breathe out all the CO2. So unless your patient is apneic, you're not going to have problems. The only other area which is problematic is perhaps in things like very severe DKA, situations where there's other ways to correct the acidosis, and even the improvement in the pH might actually worsen things like myocardial oxygen delivery and things like that. Therefore making your lactate worse. So this patient, we don't want to make their pH 7.45, but if it's 7.05, we probably want to make it 7.2 or something, 7 to 7.25, and with a very slow administration of bicarb, or with CRRT, depending on what the other metabolic needs of the patient are and what their volume status is. But there's ongoing studies to see whether early use of bicarb might spare RRT and improve patient outcomes.
But in this scenario, if there's a need for fluids, then bicarbonate would have been fine, would have been safe. Yes.
Last question.
Sure.
So it's in this case, the platelet count had dropped to 21,000 something. INR was 3. So would you prefer citrate anticoagulation in this case, or would you still go with the heparin anticoagulation? There was no active bleeding in this case. And the question about the first case, the earlier case which we had discussed, why that patient was not offered SLADE or a regular hemodialysis and was offered CRRT for fluid removal, because she was hemodynamically stable, the earlier case.
This lady with, the previous one, the HIT patient, she was otherwise. We were concerned, she had CRRT, because she was in the high dependency unit, she had a cardiac problem, her blood pressure was stable. I don't really like the word stable. She was not on any vasopressor support, that's correct, but her blood pressure was pretty labile. and she needed to have fluid removed. And we felt with CRRT we just had much better control because the CRRT allows you to remove the excess fluid over a much longer period, so less per hour.
So would a scuff or aqueducts had helped better in just fluid? Because the problem was fluid removal at that point. It was not acidosis, no hyperkalemia, nothing.
That is correct. But she had quite significant acute kidney injury and needed some clearance as well. So there's the easiest, and we thought the most beneficial form of therapy was CRRT. We've just been reminded, there was one more question. You had one more. Citrate here. So although she had an INR of 3.1, she was a liver patient, and liver patients are endogenously prothrombotic. So we started here without anticoagulation. The filter didn't last for long. And then she had citrate, and she metabolized it very well. She was able to metabolize citrate. And you don't need that much liver function to tolerate citrate. It's really the acute liver failure patients who may get into trouble, but she tolerated it. And the first filter clotted very quickly despite the INR of 3. I mean, all the cases highlight is that the questions or the decisions are not black and white. Sometimes they require discussion with your colleagues so we all see the same. And then they require the ability to predict what will happen next. And will this carry on? Are they going to turn around very quickly? Or will this be a process which will, even in the best circumstances, still take a couple of days to get better?
Okay. So I think those were two very, very interesting cases. And I think I particularly like the HITS one because it's something very rare and just a reminder to myself again to think about it. So I think the next one is a bit definitely much simpler. So this is a 75-year-old, 90.6 kilo gentleman with significant history for diabetes, hypertension, or previous CVA, bypass surgery done many, many years ago. Had a CRRT pacemaker in December, had some non-sustained VT on Holter, and he was admitted to the hospital for a fall. And when they interrogated the recordings later, they did confirm that there was a VT at home. And then as he was in the A&E being attended to, he had another VT and BF collapse, and eventually the right ventricular lead was extracted and this device was upgraded to a CRTD. So he was recovering in the ward. Management was being optimized for congestive cardiac failure. He developed fever, about 102 Fahrenheit or 39.3 centigrade, became hypotensive, drowsy, edematous, decreased air entry at both bases. A bedside echo, the IVC was full. He was commenced on inotropes, dopamine, and IV antibiotics, and then transferred to the ICU. This was his X-ray when he was admitted to the ICU, and these were his ICU labs available at that time. I tried to convert the units. I think here they use milligram per deciliter, right? So I've tried to convert the units, I think, though now I find it a bit difficult to understand them, but yeah, these are the labs available to you. So of course he has just an elevated total wide, a bit of thrombocytopenia, lactate is 4, ketones were okay, the procalcitonin was 62, CRP was elevated, the pH was about 7.39 with a base excess of 0.67. The blood pressure was 88/54 on IV dopamine, and then IV noradrenaline was added. The blood pressure improved to 114/41. He was anuric, 0 ml of urine in the preceding 12 hours. So the question again is, would you commence dialysis? So just a show of hands, how many yes and how many no? Okay. So we have a couple of yes. Yeah. Okay. So again, in the interest of time, I would just move forward. So very similar to what happens with Dr. Marlies' unit. One of my colleagues again indicated, no emergent indication based on the recent trials that were published, right? And the decision was made for medical management of hyperkalemia, metabolic acidosis, and fluid overload. IV furosemide was given at a dose of approximately 1 milligram per kilogram body weight, both as a diuretic challenge and as a furosemide stress test, like our colleague, I don't know whether Natacha is here. I think his unit had published on the furosemide stress unit as a kind of a tool that we could probably use on deciding whether to commence dialysis on this type of patients. And of course, after that, the progress was that this patient continued to deteriorate, landed up on mechanical ventilation, furosemide and hyperkalemia management, no response, remained anuric for another 12 hours in addition. So, of course, now how many would you start how many of you would start dialysis or not? I know Professor Mehta will say it's 8 hours too late already. Yeah, but I think, yeah, there was probably an agreement because the important point again is trying to anticipate the trajectory, and this gentleman has progressively worsening inotrope vasopressor requirements, worsening acid-base status, he's obviously in fluid overload, the x-ray is all full, congested with pleural effusions. You've given him a good dose of diuretic, he's not responding to diuretic, so in all likelihood, I don't see him turning around the corner in the next 24, 48 hours. Yeah, which if we did wait based on the trials, he would probably land up with an emergent indication in more than 50% chance. And the other thing that we always need to remember about trials, there was a subgroup of patients who are excluded. So those patients with end organ failure, be it liver, be it heart, or kidney failure, advanced CKD in the background, these were not recruited in the timing trial. So I think we just have to be wary about when we are dealing with these type of patients because their phenotype and trajectory may be different. So this was a CRRT prescription. He was done by a femoral catheter, 20 cm on the multifiltrate probe platform at a dose of 35 mils per kilogram per hour in anticipation of hastening the correction of hyperkalemia and acidosis. Blood flow was 200, equally distributed, the effluent was equally distributed into dialysate and replacement fluid. No anticoagulation was chosen. So we are a bit conservative when it comes to citrate because I think in the hemodynamically ones and especially for our cardiac patients, I somehow realized that they don't respond very well. Anyway, the filter clotted after 6 hours. So again, what are your considerations? Would anyone want to take this? We will aim to finish in 5 minutes, so we just have to rush through this. Anybody wants to take? I mean, we have discussed a few things repeatedly since, yeah? Okay, so vascular catheter, anything else?
The entire replacement was post-filter.
Considering the dose post-filter, I guess filtration fraction would have gone quite higher, and so
right.
Filter clot.
Yeah, so I just wanted to share this thing. So this is just an attempt to try and organize a thought process when you are seeing a filter clotting unexpectedly or in less than what you anticipate time, which actually there's no time to be honest. So I generally go through this thought process. The first and foremost, the commonest reason is usually the vascular access. And so you look at the vascular access, and if you identify a problem, you want to fix that problem first. And like on the previous case, that's the commonest thing. Now, if it's not the vascular access, sometimes it's the machine malfunction. So sometimes there is an air in the tubing or a bubble or a clot that just went and clogged the filter. So you also have to go back and look at the machine. The third part is, of course, looking at your prescription per se. So some of the points that were highlighted already, the modality, the filtration fraction, the use of anticoagulation, whether I could do a pre-filter replacement or post-filter or change the modality to a purely diffusive modality. Nursing factors are very, very often not considered, but believe you me, they do play a role. And a very, very common factor, and which I've actually timed it once, is an alarm goes off, the blood pump stops, and of course the nurse is busy doing something or there's something that takes priority, and that alarm could the filter could just remain, the pump could just remain stopped for a minute or more, and before the alarm is addressed, right? So this is a very common thing that happens. And the other part is usually when they are changing or things, so if there are new nurses or they are not, the access pressure may go very low, and then there will be a delay in response to alarm. So you should always go back. Then of course, if the priming has not been proper, that itself could lead. And now if all this is clear and you can't find an identifiable cause, always think of rarer causes. And in septic patients who are on heparin anticoagulation, antithrombin 3 deficiency, hypertriglyceridemia, heparin-induced thrombocytopenia that we just heard about, right? So whenever this happens, you try and always go back and look at the machine log, and then you just see the access alarms are just all over the place. So you know probably what the problem was. And like we had discussed and highlighted, the access in this patient was sitting somewhere in the lower part, in the sort of proximal part of the common in the iliac vein. And therefore, there was a lot of problems with the blood flow. So rightly, the access was changed. The blood culture by this time came back positive for Proteus. And as you plan to resume the CRRT, would there be any other considerations or modifications to the dialysis that you would consider? Sorry, the access has already been changed, by the way, yeah. Any things you would think about now that you have this information? Only 2 minutes, so we make a comment very quick. Okay, so I do not know, and I must confess the literature out for this is not in form of a robust randomized controlled trial, but there are reports out and case series out, and there's a lot of kind of collective data that is coming out that there may probably be a role of cytokine absorbing filters in the management of sepsis and patients with septic shock. So since we had this opportunity, we decided to use an oxyris hemofilter with the attempt to try and absorb more cytokines and see whether that helps this patient. Essentially, the prescription was kept very much the same. I can't pinpoint you why whoever had chosen not to do citrate anticoagulation. I'm sure there would be many here who would want to do it, and expectedly the filter clotted again in 12 hours time, right? So again, we just go through the same thought process, and when we looked at the filter graphs, you can see the access is not a problem. The red and the blue return line and the access line, they're almost straight, which your access is not causing you a problem. And if you track these graphs, you know that this is a filter that has clotted, right? And therefore, your strategy then, when you review your prescription, is to ensure that this patient receives an appropriate and adequate anticoagulation. So I'll just stop here.